Good afternoon, and welcome to Health Leaders, the Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know most. My name is Eric Wicklund. I'm the Senior Editor for Innovation and Technology here at Health Leaders, and I'm going to be the moderator for this session. Today's webinar is titled The Winning Edge for Using AI to Improve Care Management. It's sponsored by Lightbeam Health Services. Thank you to our sponsor for making today's program possible, and thank you to our audience for participating. And I understand we have a big audience today, which is going to be great. Before we get started, I do have a few housekeeping details to go through. Our program will be 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel on Friday, and this can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for this event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you'll find a resources list for today's webinar in the upper right corner of your screen. Here we've listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events. As I mentioned, we have one of these every week, different topics, a lot of fun. At the bottom of your console are multiple widgets that you can use to submit a question, and we will have a Q&A portion of this program. It's usually the last 10, 15 minutes of the show. To submit a question for that Q&A portion, you got to click on the Q&A widget. It may be open already and appear on the left side of your screen. You can submit questions at any time during this hour, but please note that they'll probably won't be answered until that Q&A segment. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which is a question mark icon and covers common technical issues. Excuse me. Now comes the fun part. This time it's my pleasure to introduce our panelists for today's show. We have Danielle Bergman, AVP of Clinical Development for Lightbeam Health Solutions. Ishani Ved, Director of Transformational Population Health and Outcomes for St. Peter's Healthcare System, and that's out down in New Jersey. And Mike Wells, President of OSF Healthcare St. Francis Medical Center in Peoria. Thank you all for joining us. And with that, let's get into our discussion. And question one is perfect because this gives you guys a chance to talk a little bit about yourselves, and also tell me a little bit about, what's your AI strategy for care management? Let's start with Danielle on this one.
All right, thank you. So hello, everyone. I'm Danielle Bergman. I'm a board-certified family nurse practitioner. I am the AVP of Clinical Development here at Lightbeam Health Solutions. I spent over a decade in healthcare, starting in critical care and then evolving into clinical AI. So at Lightbeam, I lead a team of clinicians. I collaborate with our data scientists, validate prescriptive AI solutions that help these healthcare organizations reduce inpatient or avoidable events, address social determinants of health, but ultimately improve patient outcomes. I am passionate about making technology more meaningful and actionable for clinicians, which is our primary end user.
Okay, I forgot to mention too, you're down in Florida. Let's move up the coast a little bit to New Jersey. Shani, tell us a little about yourself.
Hi there. Yeah, so great to be here. I work for St. Peter's Healthcare System. We're a Catholic standalone hospital in the middle of New Jersey. We are going through a merger with a larger system, but we really have such a passion for population health, and we've been doing this for over 100 years. Before we called it population health as part of our Catholic ministry. So we've been so excited to really bring in this new technology, cutting edge in the work that we're doing, because there's so much work to be done, so many patients to be helped. And, we've been really excited to use AI to help manage those populations and then prevent any downstream effects, regardless of what payer our patients have. Happy to be here.
Nice. Happy to have you too. Mike, let's go out to Illinois with you.
Sure, I'm Mike Wells. I'm president at OSF St. Francis Medical Center, which is a large hospital in central Illinois. We're a 642-bed hospital with all levels of inpatient care. We are the flagship of OSF Healthcare, which is a 17 hospital system really spread across Illinois from border to border and into northern Illinois with an outlier out in Escanaba, Michigan, interestingly enough. We have comprehensive outpatient services in oncology, neurology, cardiovascular, and children's care. We have a children's hospital within a hospital here at St. Francis Medical Center, which is actually where I spent most of my career. I've been with OSF for 20 years. 18 of those years were in the Children's Hospital of Illinois, just most recently serving as the president of the Children's Hospital. In terms of AI, our strategy is really leveraging this innovation to support our organizational outcomes. And so excited to be with you guys today. I will give you full disclosure. I'm not an AI expert. In fact, I was telling my wife last night that I was going to be on this AI webinar, and she was like, "Oh, that's cool. You're going to learn about AI." And I was like, "Well, I'm actually on the panel teaching other people about AI." And she was like, "Oh, well, good luck with that." So I am here as a healthcare user, and hopefully you'll learn some tips from our journey so far.
Certainly agree. And we won't get into too much of the details because I don't know them either. I just write about them. I let other people talk about them. But we've got a great topic here. Certainly with AI, it's the bread and butter of innovation right now. Everybody's talking about it. A lot of the early wins were administrative, especially in rev cycle finance, handling data crunching, getting the numbers out of the way, handling the administrative tasks that people would do. And by doing that, you're giving people more time to work on other things. Now that AI is moving into clinical care, we're seeing some very interesting applications. I know it's too early to say AI is going to save lives or really change clinical outcomes just yet. It will eventually. But for now, the topic what we're talking about today, care management, that's where some interesting uses of the technology can be found. And that's what I want to talk to you about, is how you see AI being used in care management, and where you see it going in the future. And our first question, we'll start with, and I'm married to a nurse, so this is one of the big topics, nursing. How do you see AI being applied to the nursing workflow? What tasks could AI handle for a nurse? Ishani, let's start with you on this one.
Yeah, so calling on my past life as a director of quality for our healthcare system, I don't think that ever leaves you. And we've had a long-standing relationship with Lightbeam where we've used multiple iterations of the tools that they've provided us. And what we know about nurses is that they have task fatigue and they need to be working at the top of their license. So fortunately or unfortunately, as these, in the realm of population health, new regulations come about for screening, we know that the onus falls onto the nursing staff if we don't step in and try to find a better way around it. So what we've done in the outpatient setting, where we really use this technology, is to help find those patients when we might not have ever met them before, just due to the nature of the population we have in New Jersey and in our service area. The tool helps us find patients that are high and rising risk so that our social determinants of health coordinators can intervene there. So you're not at the nursing level, but you're at that professional level where you can help people close their gaps. And then what we'll do is give that only pertinent information on what the action items are for nurses and for our providers on what they might be able to do: medication assistance, medication reconciliation, providing information in such a way. So really, I think we have a lot more to see of how this can affect the nursing profession. I do have a nurse on my team, so that's very helpful. But we really try to take the burden off of our clinicians through the use of this tool here.
It can certainly help them with their workflows. And we all know that stress and burnout are huge issues in the nursing ranks. Mike, how are you seeing AI applied for nursing?
Currently, we're really in the generative AI space. And so, as you mentioned earlier, AI is capable of very rapidly taking a huge amount of data analyzing it and providing it to a user, in this case, nurses, care managers, to act on. And so we have utilized an application that takes a huge amount of information from a specific patient's history and provides guidance to the nurse or the care manager in terms of care planning for that patient. Things can be proactive, like, hey, try this. This was effective last time. Or it may be, hey, you ordered this and that's different from what you ordered last time. Or it is something that didn't work well last time. And so can provide that kind of, hey, are you sure that's what you want to do? Prompting. So we have that application in play now. We have an ambient listening application that we piloted in our outpatient setting. And so, this is where AI listens to the conversation between a provider and a patient, and then kind of screens out all the unnecessary information and summarizes an encounter note for the provider. So this saves tons of time for the provider. The provider then reviews the note for accuracy and just saves tons of time that they currently spend documenting by having AI do that for them. You mentioned predictive analytics. We use predictive analytics to identify patients that are at risk for readmission or emergency department visits or even mortality, and provide then guidance for the care manager or the nurse in terms of care planning, more long-term care planning and connectivity to the outpatient setting. We are about to, that ambient listening application that I mentioned, we're about to implement that on the inpatient side. So that'll be interesting, because on the outpatient side, it's really a specific encounter in an outpatient setting, which is a little more controlled, and it's really dedicated to that, 15 or 45 minutes, depending on the appointment. In the inpatient setting, it's much more fluid, right? And so this would be, again, listening in on the conversation between the nurse and the patient, the case manager and the patient, and then providing documentation. So that'll be interesting, because the other thing that's unique about the inpatient setting that's different from outpatient is it's not an encounter note. It really is entering data about the patient into discrete fields. And so it's a kind of a different way of getting information into the patient record. In addition to that, really just a lot of different applications that we have implemented or are trialing to help with the prioritization of tasks. And so do these things first because they'll have the greatest impact. Or, hey, watch for these patients because they're, nearing discharge and we haven't done these authorizations. And so really just helping the person manage their workload more efficiently.
Yeah, not a lot of health systems have used ambient yet in the nursing space. It's going to be interesting to see how that's done. They are seeing success in the the doctor's visits, really. A lot of health systems are doing good things with that.
Yep.
But yeah, as you say, the inpatient space, the hospital room's a little bit busier and a little bit more complicated. So it'll be interesting to see how that works out. Danielle, from an industry perspective, how do you see AI being used to help nurses?
Yeah, and it kind of, just to sum up what everyone just shared, we know the environment that we're currently facing with like rising shortages, time is a scarcity, resources and burnout. So I think, from an industry, AI can really serve like kind of the summary of those two use cases as a clinical ally. Really, the goal is to offload mental bandwidth for our end users that is required to manage these specific at-risk populations, whether it's, the population health from Ashani, and then, the inpatient setting, even on offloading those tasks. So I think that's where the biggest opportunity with AI is to prioritize time, resources, knowing what action to take next, knowing who's going to deteriorate next, with the goal of not only making it more efficient for clinical care, but also prioritizing at-risk populations so that we can intervene more proactively than reactively. There is an industry shift of, that value-based care model where we're wanting to shift to proactive care outcomes, addressing, the patient experience, addressing the cost of care. So I think that's, an industry perspective of what's our current state today, of what's working and what we're seeing value in. And then as we move to kind of future state, I do, we're going to evolve quickly. We know technology is moving rather quickly. One of the biggest things is the next step of how does this all look automated? Can we automate AI's output to automate referrals, automate tasks that we don't need to bring the human in? So we don't need to bring those care coordinators in to just make a phone call and assess what is their income for SDOH. Now we can automate, does that patient need income assistance? Does this patient need? So that's where I think, in at LifeBeam, we're leveraging our partnership with LifeBeam AI and CareSignal to start that automation, because that's really where the next step, I believe, is going to be not only making it more efficient, but then now offloading what can be offloaded as appropriate.
Yeah, certainly. And you have the promise of AI is that you can take away the task to put nurses and doctors in front of computers and laptops and put them in front of people, put them in front of their patients.
Get them back in front of the patient, right? Yes.
Okay, let's see. That's our next question. Okay, we've talked a little bit about the benefits. Now let's talk about the challenges. I'm going to start with you, Mike. What are the biggest challenges you see in developing AI in inpatient care?
One of the things I think that's a challenge just in incorporating AI into patient care or healthcare in general are the risks, right? Because in implementing AI in healthcare, we're not just using AI to help write a speech. We're using AI to provide care to humans, and there are literally lives at stake. And so one, I think, is doing this with the right amount of caution, ensuring accuracy, and making sure that we really are implementing AI in a way that it optimizes the human that is still so important in providing healthcare. So one is that, just the use of caution and implementation in general. Another is, as we talked about a little earlier, there's a lot going on in the inpatient setting. There are lots of people in and out, lots of things that are being monitored. And so it's not quite as controlled as the outpatient setting where we've done a lot of implementation, or on the rev cycle end where we've done a lot of implementation. So this is really a new area for us. Think about things like virtual sitters, which we've implemented a long time ago. These are, for patients that are either at risk for falling or patients who may be prone to wander. And so we have a televideo presence by someone who's literally just keeping eyes on the patient and alerting the nurse or another staff member if the patient gets out of bed or starts to wander. And we're contemplating using AI as a computer visualization so that the AI is actually watching the patient, knows what actions indicate getting out of bed, and alerts the caregiver or the nurse, the tech, to come into the room and address that with the patient. And so as we transition, we've had great success with the virtual sitters. As we transition to this, obviously the benefit is we can optimize the human time. So we would still have humans involved, human in the loop, but we would be able to keep an eye on many more patients because AI would have the ability to do that where the human is limited. And so as we do that, though, really managing the risk and doing tests of change over time so that we can implement that really safely so that we don't start to experience an increase in falls, which all of us hospitals are focused on minimizing. I mentioned data assurance. And so, some of the AI that we're working with now is not quite as, I'll use the word simple, but that's probably not the best term, as simple as the stuff that we've used in rev cycle and in the outpatient setting in terms of testing. So like predictive analytics, for example, again, a way oversimplified explanation, but we predict that someone is going to readmit. We compare that to another population, and if they readmit, then it worked. Our prediction was accurate, right? That's a little easier to test than in the inpatient setting where we're starting to move into that more complex data analysis and application by a user, or as Danielle mentioned, kind of the next level, figuring out then where are the opportunities to give AI more autonomy to actually act on the information. So, the example there being care manager has information about the nursing homes that we want to discharge to, or the psych hospital that the patient needs to transfer to. then giving AI the autonomy to go ahead and connect with those nursing homes, provide the information, rather than our care manager waiting for a callback or waiting on the phone. And so really just carefully identifying those opportunities to preserve the time of the human, as we kind of move into this more complex space, and being able to really assess the accuracy so that we make sure that we're, using accurate data and kind of mitigating the risks that come with that. So I think, there are certainly challenges that come with the different environment, but also as we get more and more complex, there are just challenges that come with the need to ensure that that data is accurate and that we've got the right tests of change in place to make sure that it is.
Certainly, yeah. It wasn't too long ago that we, when you talked about sitting, that was actually people sitting in the room with the patient watching them. Now we've moved on to telesitting, which is people in another place, and now eventually it's gonna be an AI infused camera that watches the patient. It is interesting. Shani, what are the challenges you see in using AI?
Yeah, so using AI in inpatient care, just pulling it back a little bit, I think one of our biggest questions was, how do we maintain that trusting relationship with our patients and also be upfront about the fact that we're using AI? So we've really developed a culture with our clinicians and talking about the benefits and the limitations of using that. So it's, again, not in place of a human making a decision. It's here to empower our clinicians in doing the right thing and using their time better. Also looking at the models that drive our decisions. Is the data that backs up the engine that we're using similar to, or does it represent the patients that we are managing? So that's an important question as well. And the great thing about this process is that we're taking recommendations for high risk individuals or medium rising risk individuals that have had some sort of event, either if they're in an inpatient bed now or they were recently in an inpatient bed. That's usually the patients that we're managing on the outpatient side. We at least know enough of that information that they might not have told us actually when they come through the door, that this is a rising risk, where they might not have thought of themselves as a risky patient because they live on a block where there are volatile organic compounds which might be affecting their asthma, and they're not thinking about it. So it helped us close that gap. But again, we have to be careful how we talk about how we're using this, and we really engage our clinicians in, hey, this is the right thing to do. So we've been fortunate to have a department of medicine that's really partnered with us on this and championed this. They think that we're really on the cutting edge, and I do believe that we're doing things that are on the cutting edge. And you have to be comfortable with living in that unknown, or knowing that whatever we're doing and feeding back into this machine learning platform is helping the products get better because they're learning from us. So I think that's just broadly, when you look at AI, it's a reflection of our collective. I was just talking to somebody about this, our collective brain power, because it's been built by human beings. So it's great to be able to add to that body of knowledge and further that along, because I think it's only going to get better for us to use it in patient care in more settings, especially as regulations change about screening and you have to do more with less. It's a great tool to have in your toolkit.
Yes, yeah. As you mentioned in the beginning too, part of the challenge of AI is managing the hype surrounding it. Everybody has these ideas about what AI can do, what AI should do, and what AI shouldn't do. And in healthcare, that can be tricky. Danielle, are you seeing, is it an issue to deal with the hype surrounding AI? And, what are the challenges that health systems have in using this technology?
I mean, and well, one of the biggest challenges, and yes, there's a lot of hype, but there's also, to what both Mike and Ashani said, is the clinical trust, the buy-in, right? The believing, and that the models do have to be transparent. They have to be clinically explainable. As a clinician who has worked with data science teams, even the best performing model won't succeed if your clinicians can't understand or validate the output. If they're not buying into that and don't understand what it's intending to solve for, that's the other challenge, is the trust. But then the downstream of that is the workflow, because if it doesn't fit and it's not explainable, and in this case, we're talking about inpatient setting that's fast-paced, lots of providers, lots of folks involving into one patient. And if the AI is not being delivered in the right place at the right time, it's going to get ignored in clinical workflow. In all honesty, it has to fit into that workflow. It has to feel seamless. We know clinicians are inevitably, change management is a hard principle in healthcare. And so we have to work with, minimizing that burden that does come when you bring a tool in. It has to feel like it's contributing. It's informing clinical decision-making. It's augmenting it. It's not creating an additional burden, because we already have too much of that in the healthcare environment with workflow. The other side, the last challenge as an industry, is the data. So inpatient, there's a whole different beast of data requirements, right? There's a lot of data fragmentation because we have the EMR, we have the SDOH, we have claims, and some patient. So there's all these different data sources. So that is, if I were to say industry speaking from an organization, that's a big challenge and hurdle. But from the workflow, and to speak to what we just all talked about, it's definitely building trust, and then making sure it does fit within the clinical workflow is really key, particularly in this fast-paced inpatient setting.
It certainly is. It's all about the data. I mean, that's all that AI is. Basically, is analyzing the data. The ability of AI to analyze more and more data than people are normally able to is where we could see some great things. Okay, we touched upon this a little bit in talking about managing the hype and getting buy-in. And this is the question: how do you achieve nurse buy-in and physician buy-in? I'm going to stay with you, Danielle, on this. What have you seen from your customers, the other health systems out there? How are they getting that buy-in?
Yeah, and I will say, it's kind of piggybacking on, or like continuing where I was going with, buy-in is also part of how it is implemented, in an organization, especially for, your clinicians, about workflow. And the goal is to demonstrate that AI is here to make work easier, right? It's here to augment clinical decision-making, inform clinical decision-making. It is not intended to create an additional burden on workflow. I think what has to be done is clinicians need to be trained to understand the value and to understand how it is intended to improve clinical workflow. And then if you can educate and demonstrate that these tools are here to help prioritize high-risk patients, they're going to reduce time spent on redundant tasks, then you'll get the engagement. Once clinicians do have that first aha moment or that positive encounter with a patient due to the information that was presented to them, it really spirals from there. It's the initial almost kind of, I feel I hate to use the term hill, but it's a shift. There's a shift that has to occur when we bring in technology in healthcare, and especially with clinical workflow. And, you said physician buy-in. And so that's not always, in the topic of today, it's not always care management AI, but if there is provider buy-in, so if the full care team, so similar to what Ashani said, if you have a department that's on board and it's including multidisciplinary teams, you're going to have a powerful layer to really bring in adoption and utilization for AI. So having the full care team involved in the same goals and believing in where this is taking, I think that's a key. And part of what we do with an organization is educating and ensuring that we do have key stakeholders involved to share in that ownership and integration, both in the clinical and non-clinical workflow. But those are two powerful components together.
Yeah. And we all know how healthcare and technology have mixed in the past. If anyone remembers meaningful use, it's been a challenge. Shani, was there any pushback when you first introduced AI, and how did you get everyone on board?
Sure. Yeah. it's important to drive the point home. And I think this was the heart of it. Why do we have to do one additional thing? Is this going to add value? And I think it's really about tying it back to those things that Mike mentioned early on is you're really in real time, and we've proven this, even if it's a Hawthorne effect, even if you're just talking about bringing this to top of mind for patients, but by addressing people's social determinants of health head on, looking at their risk factors, having that conversation and mitigating them with real things like food and transportation. And you show your clinicians that if we find these folks, we make sure that they get to their appointment using transportation. That's one of our biggest wins, honestly. And that they're able to be referred to our in-house food pharmacy, which, people call it different things, food is medicine program. We have an in-house clinic. Those types of real interventions that come as a result of using the technology is really what helped our clinicians see the value in what we're doing. And the fact that we're able to take something off their plate and serve it back to them in a very compact format. We write them a note, say, hey, this was the risk that was brought up. These are the things that I was able to mitigate. All I need you to do is make sure that we get this patient prescription assistance. They immediately see the value. And then they realize that, hey, our patients are 7% less likely to have an inpatient or ED visit after this intervention, even if we don't get to everybody. So I think it takes time. You can't expect them to immediately trust something, especially because the word AI is being used so loosely in the industry that people don't understand truly what it is, or that there might be some fear about it. But I think you have to prove it to them and put it in their terms of, and as a provider, I'm sure Danielle can feel that. Even our APNs, they see great value in that. And
yes, absolutely.
It's possible. Definitely.
I like that we have moved, and I've seen it a lot now, that used to think of AI as artificial intelligence. And I think a lot of people are realizing now that we can call it augmented intelligence instead. It's certainly a much better description of how this technology works and what it can do. Mike, same question. How do you get buy-in? Is it a problem?
Interestingly, it hasn't been a problem. When we implemented ambient listening, we required the patient to consent or opt in. Less than 10% of the patients chose not to opt in. So buy-in was high at the patient level. We did surveys then of the providers that were using ambient listening for documentation. The feedback was overwhelmingly positive. They liked it. We did surveys of patients. Feedback was overwhelmingly positive, that they felt that the provider or the physician was taking the time to listen to them because they weren't focused on documentation. They were focused on speaking and communicating with the patient. So really, and in fact, when we did, some outcome metrics related to, did we actually save time? We actually did. And there was less time spent after hours doing documentation. And so, to Danielle and Ishani's point about making sure that these are credible and then providing that feedback to the users, we were able to do in that instance. And so we actually are kind of taking a look at the other side of it, which is managing the enthusiasm about the utilization of AI. And what we're finding is that in some cases, buy-in is actually outpacing the user's understanding of AI. And so you've got the, examples of the physician who uploads the X-ray into ChatGPT, which we do not want to do. And we want to make sure that, we're providing safe, credible, HIPAA compliant ways to use AI that really are making a difference. And so that in some ways has been a challenge for us, is that we know if we don't get those things in place, there are going to be users who move ahead of where we're even at. And so there's the other side of it too, is just kind of managing the enthusiasm because there is so much buy-in already.
Yeah. One of the issues here too is that AI is very democratic in how it's being deployed. Consumers are seeing it used everywhere. And so they want to see how it's used. They want to use it themselves. And then they're going to go recommend it to their doctors. And so, yeah, you got to watch out. You got to rein in the enthusiasm sometime on this. Okay. Now, is this a good progression for this discussion here? And I do want to point out that we have zoomed past the half-hour mark. So we're going to keep on going. I've got plenty of questions. I will keep track of the Q&A. And then again, to the audience, send in your questions. We will have a Q&A session, and I will be peppering some of those questions into this program. For this one, though, I kind of want to progress from, we've talked about the benefits, we talked about the problems, the buy-in. Now let's talk about sustaining an AI tool or program over the long term. How do you prove its value, its ROI, and how do you find what you need to find to be able to keep using it? Nishani, I'm going to start with you on this one. How do you measure your programs for sustainability and scalability? What are the KPIs you use to prove value?
Yeah, we have a great data support team on the Lightbeam side that checks in with us on a monthly basis. And so what we've done is biannually, at least every 6 months, we check in and we say, of the cohort of patients that we have had an interaction with, that we screened for social determinants of health, that we looked at their risks and recommendations, and we had that interaction with them, what was their 90-day post events, inpatient visits, ER visits, things of that nature. And we've just seen and monitored that rate, which has been pretty consistently at 7% in plus or minus a percentage of, you're less likely to have one of those encounters. So we're constantly checking on that. We're also keeping track of how many patients we are screening in a month, seeing what those demographics and general information is on those patients. We've also kept an eye on, when there's a refresh of the information, which is so important. And, when I started with this relationship and going into this AI space, I didn't really realize how important it was that the data is up to date. It is reflective of your patients. That data changes. So as long as we're bringing that data in, that's one of those measures, which is like a meta measure. It's not really for the patients, but it's important to us in our strategy because it also shows us on an even more macro level where there are pockets of needs at the zip code level. So we can collaborate with our nurses that are in community outreach and say, hey, you know what? Kids in this particular zip code, this particular block, don't have access to providers the way we might, in a disparate location. So maybe we do a little bit more outreach there. That's been so helpful for us. But the short and sweet version of that really is, if it applies to this particular clinic, we do this for our adult patients. We know now that it works for all kinds of patients, depending on the information that's available to us. So it really applies to any adult patient because there's data out there to get on them. I think, you might get into murky water when you're looking at newborn risk. There's not a lot you can do there. That's the only carve out I can think of. But inpatient and ED utilization, it's black and white. You can't refute that. So we use that data. We look back and we say, what are those things that we might have missed that could have precipitated an ER visit? People will look at you funny, but we're in uncharted territory. There are things that we could intervene on. So there's a lot to be learned. I think that there's still probably more metrics out there as we continue on, but those have been our big ones.
Now, a lot of these metrics deal in clinical outcomes. You still, in these trying times, you must have the CFO looking over your shoulder too, wondering, can we justify this expense? Is that still an issue?
No. So population health is not a moneymaker on the books, but it's a money saver like quality and safety was. So I see a lot of parallels between quality and safety and the role of a quality manager and population health. We're keeping people healthy. It's at the heart of our Catholic mission. And we're avoiding negative outcomes, often, honestly, for patients. So there is a financial component. If you back me into a corner, there's unreimbursed care that's going to happen. If you have no insurance, who's looking out for you? And that's part of just the way we do business, that it's the right thing to do. So we're going to intervene. So I think the story tells itself. There was an initial conversation, but we've sustained pretty well. And we budgeted for things like this. We're not at the mercy of grants for our entire program. So we've definitely prioritized the technology component of it to be a part of our budget.
I like that answer. Thank you. Mike, same question. How do you work on sustainability and scalability with these tools?
Sure. Similar to Ishani, really our ROI is demonstrated in things like improved productivity. So we're, reinvesting time elsewhere that is quantifiable in terms of financials or quality outcomes, revenue gains, cost reductions, and as I mentioned, quality outcomes or patient impact are the things that we typically are looking at. A few examples, I mentioned how we sort of assessed the impact of our ambient listening. We also did a similar project around an advanced care planning application for AI. And so in this scenario, we identified patients that would be good candidates for advanced care planning. So they were flagged. Then we used AI to reach out to those patients and start to gather some information and provide them some guidance in doing advanced care planning. We measured the number of patients that were engaging in advanced care planning and advanced care plans that were developed. It really skyrocketed, so much so that at the end of this loop, there were humans that were engaged with the patients in the care planning. And we had to actually add human resources because there were so many patients that were engaged in advanced care planning. And so just that one example, pretty significant impact. As we implement this on the inpatient side, we're focused closely on things like length of stay. Now, for us, we tend to be a very busy medical center. And so as we're always focused on throughput and making sure that patients are discharging as soon as is safe, we are able then to backfill. There are always patients waiting to get in to the hospital. And so, we track our number of transfers that we can accept. We track our length of stay, and all of those things can be quantified in terms of financials. Better our throughput is, the more transfers that we're able to accept, the more procedures and surgeries that we're able to continue to move through. All of those things are easily translatable to financials. And so those are the things that we monitor as we implement these things. And I have to say, so far, we're still, I would say, early in this, but the outcomes have been there, and it hasn't been difficult for us to create the ROI.
Yeah. Everybody is early in this, really. It is still an innovative new technology that's being put to use in healthcare, and yeah, it will take a while for clinical outcomes to be affected. But I tend to think that eventually you will start seeing that data that AI is providing the right guide, the right points to improve outcomes. Now, Danielle, is this what you're seeing? Is everybody doing the same thing to prove scalability and sustainability, or is it more each health system has a different view of what the value of the technology is?
Yes and no. So there's a broad view that we see synonymously, just as Mike and Ishani, that is both the clinical process metrics. So, how are we impacting workload? How are we impacting, efficiency of like employee time? But then there's the outcome metric again, which is another broad metric, which is, reducing those events such as readmissions, ER visits, cost of care, length of stay outliers, those type of things. So that's your process metric, your outcome metric. And then the other thing that we also look at is adoption. So adoption is if you're not using it, you're not going to realize the value. So we have to have adoption in these tools in order to expect the outcomes that we're anticipating. But to your point, yes, there are specific metrics. Every organization is tracking different populations, different geographies. SDOH is different across the board of what pockets exist. So, is it improving screening? Is it improving transportation barriers? Is it, all those are SDOH, but again, is it your CHF? You have a high CHF population and we're targeting those outcomes and those high cost of care. So there are population pockets in shifts based on organizations, based on where their cost outliers are, who are their high utilizers. And that's really where we're seeing those unique, measurements or metrics that are being used. But broadly, synonymously across organizations, we're seeing both the clinical process and the outcome metrics as the majority of what organizations are looking at with AI.
Yeah, and I know we haven't talked about it much. We've mentioned it here and there, but again, stress and burnout and the fact that everybody's dealing with workforce shortages, the ability of AI to impact, to improve upon the workforce, to help the workers you do have, and to certainly make their lives better. There's value there that sometimes you can't define financially. But you can define ROI. And Mike, I'm going to start with you on this one. I know we've been talking about this throughout the last question, but we talk about value-based care, and everybody has a definition that's kind of different for value. How do you define ROI for an AI program?
One of the easiest is if you go back to some of the rev cycle applications that we did early on. The return on investment for those is pretty clear if you think about things like risk adjustment in coding. And so you are making an almost immediate impact on a pretty large population by using AI to screen and to sift through all of the information in the patient's health record and prompt additional information for the problem list that affects the risk adjustment for that patient for things like readmission, mortality, et cetera, and revenue, because you're billing at a higher rate depending on the complexity of the patient and the services that are provided. And we, in most organizations, have humans that do that. We can do it much more rapidly by implementing AI to screen and sift through all of that information and bring back those recommendations. So that is probably the most simple way that we've been able to demonstrate ROI very quickly with the use of AI. And we're currently exploring more in-depth use of that, even beyond rev cycle, in the documentation on the outpatient side. So same kind of principle, but prompting the provider then in terms of diagnostic information and care planning based on AI, reviewing that patient's record more fully, comparing that patient's characteristics to thousands and thousands of other patients to provide care guidance and diagnostic guidance with the aim of being more accurate. And there is a very clear connection then to revenue when it comes to accurate diagnosis and care planning. And then the third thing I'll say is, when we are contemplating more and more robust implementation of AI on the inpatient side, as I mentioned earlier, the focus really has been on length of stay and throughput efficiencies. And the reality is, not only does that translate to shorter lengths of stay, or I'll say even more accurate lengths of stay, so decreased excess days, which translates for us very directly in terms of revenue, because we're able to accept more transfers and complete more surgeries and procedures. And so all of those things generate revenue. But at the end of the day, it also, I believe, will result in better care. And the reality is, administrators kind of tread that line between the humanistic interest in just taking good care of people and watching the bottom line and making sure that our organization is sustainable. And I think this is an example of where we are doing both, because better care, reduced, hospital-acquired infections, shorter lengths of stay, fewer readmissions, all of those things are good for people. And they also show up on our bottom line because they are cheaper care and give us the opportunity to enhance revenue. So all those things really speak to good care and the return on investment from a financial standpoint.
Yes, nice. Ashani, I'm going to change this question a little bit for you, because you've worked a lot with AI and population health especially. Have your AI tools caused you to change your perception of ROI, or have you found ROI that you didn't expect to find when you started?
Yeah, I think there's hard costs associated with efficiency, and I think the one that really sticks out to me is reducing our no-show rate by getting ahead of patients who might need transportation that have established care with us, that we've met them. For living in a metro area, you wouldn't expect that there are so many barriers in that way. But how many patients came to their appointment and we didn't have to, overbook that slot, or we didn't have a lost opportunity in seeing a patient that day that really needed to be seen. So it just increases efficiency, which is a staff satisfier too. We have predictions of what kinds of patients will come to us in the next year, 2 years, 3 years, just based on large data projections. This utilization of AI has helped us really align better with what we see those forecasted trends being, and we're getting ahead of the curve, and we know what the most common issues are for our patients now, so that we can kind of give that insight to different layers of our organization and say, this is what we're seeing on the outpatient side, but these are the same patients that are inpatient on some of our floors, and these are the disease burdens that they have. So I think it's just made us more nimble overall, and when you're not wasting time, your staff is really jazzed about that. So that's a nice unexpected ROI. How do you measure staff satisfaction? I think that would be an entire other webinar.
Certainly, yes. Good answer. Danielle, same question. Are there unexpected? Is there unexpected ROI coming out of the use of AI?
Yes, and I will say, there's different AI models that the goal of the model is to predict adverse events, to prevent those events, to understand them ahead of time. And so to Ashani's point, like the no-show appointment, or even let's say, we have an AI model that predicts patients who are likely to have severe depression in the next 6 months. So with that subsequent prediction, you're going to have an increase in screening. You're going to likely have an increase in patient visits. You're going to have an increase in, referrals to psychotherapy, all those downstream things. While those are increasing in rates and increasing in volume, what is the downstream effect to the patient outcome, right? That's the ultimate goal is, yes, there's going to be shifts in uptake on certain models of we increase no-shows, we increase appointments by getting them in, and we have more volume. But what is the downstream effect of the quality of care, the overall cost of care, the acute care needs? So it depends, I would say, on AI models. That's where, you asked about the unique use case and the unique ROI for this, and that it depends on what problem we're trying to solve. Broadly speaking, it's the clinical, financial, and workflow efficiency is where we're looking at, and that's the broad downstream effects of what is the result of all of these models. How are we solving the problem, both financially, clinically, and then the effect workflow effectiveness. And then, I think another way to downstream, like, can we measure burnout prevention? Can we measure, clinical satisfaction, provider satisfaction with this, even though subjectively that could be skewed, but I think there's a future state of how this affects satisfaction in care teams.
Certainly, yes. We've only got a few more minutes left here. I think about 8. So I'm going to jump to a question we got from the audience. I'm going to start with you, Danielle, on this. Are there protocols for keeping a human in the loop? That's a popular term, and I know we're still early in AI that you really do need a human in the loop. Are there certain rules for when a human should be reviewing all aspects of AI?
And so there's two sides to that, because I would almost ask the person who submitted it, are we talking of human intervention on workflow? Is it the user? Or is it behind the scenes at the organization who's managing the technology? So, so I'll go both swim lanes, really, because it's essentially, as an organization with AI, yes, are you having clinicians actually validate the output of those models? Does the organization have a clinical team that's reviewing the data, understanding the output, validating the performance and the metrics that are required before it goes to a clinical end user? I think that's a key, clarifying question for this attendee. And then the other side of it is AI is intended to inform and augment clinical decision-making it's not here to replace, is I think the summary of what we talked about today, right? We're not here to take clinicians out of the equation. We're here to keep them, that human interaction in place, by creating more efficiency in workflow, by offloading tasks that truly can be automated. Do we need a human to click the button for a referral to a dietitian? Not necessarily. That's a task that could be automated, right? And so that's where, the goal is to keep the clinician in front of the patient with more efficiency while improving those patient outcomes. So I think it depends on what side of the fence we're trying to talk on when we're talking about protocols here.
Yeah. Okay. Shani, same kind of question. Are there rules for when a human should review AI?
Yeah, every interaction has at least one human taking a look at it, and we say, hey, what we're seeing makes sense. I mean, we're not taking anything at face value. We say, this is what the tool says that my patient might look like. Is this what I'm seeing? Yes, no. Give feedback, and we just keep getting better because of it. And if we didn't have something like that, I think our clinicians would be much more wary about it. But once you've seen enough patients using any sort of solution with AI, and you can make sure that it is valid, I think we owe that to our patients. That would be unsafe if we have no idea. So at least one person will validate that per patient on our end.
Okay. Mike, same question. What's the human in the loop protocols?
Same, really. We do human validation. So, as we do these tests of change in terms of our data assurance, part of that is always human validation. And the same as Danielle and Ishani said, we are really trying to optimize what humans need to do, right? And so optimize the human to focus on what humans need to be doing, offloading tasks. Classic example being, we have case managers who spend an incredible amount of time on the phone or waiting for callbacks when they're trying to get patients transferred to SNFs or psych hospitals or other places that they need to go. That is a task that AI could do reliably and efficiently, effectively, thereby freeing up the case manager's time to do things that only the human can do. And so that really is the focus of what we're trying to do. So, and I believe that there will always be a human in the loop, because in healthcare, our goal is not and should not be to take the human out of it.
That's good. Okay. We're only got a few minutes left. I'm going to go with one more question, and it's mine. I want to kind of look in the future a little bit with this, because AI is such a fun thing to talk about in terms of potential. And I'm going to start with you and Mike on this one. Where do you see the next big win for AI in clinical care? What do you want to use it for next that you think it's really going to make a difference?
I think that this, to me, is similar to the impact that genomic sequencing had on diagnostics and care planning and pharmacology. So I think it's that magnitude of change. We've been using generative AI data analysis and providing that to a user. I think the next thing is to give autonomy to AI appropriately so that AI can actually take action on the data. I think that's the next big thing. So we'll use that sitter example. In this scenario, AI is prompting a human to do something. Wouldn't it be cool if AI could actually interact with the patient and, preemptively stop the patient from getting up rather than having to prompt the person to do it? So that's kind of the next big thing, I think.
Wow. Yeah, interesting. Okay. Ashani, same question. Where do you want to use AI next?
Yeah, on the data analytics side, absolutely. How can we further leverage the technology that we have to predict more specific outcomes? If you have family history, just like Mike was saying, of certain diseases, what is this person's propensity to land in that same place? And what our mantra, and I'll tie it back to this, is we want to make people more productive members of society. My own personal ethos is you got to give people enough information and autonomy and ability to make those informed health decisions for themselves. So I think there's a lot to come in terms of, patient-specific medicine when it comes to AI. And, just as we collect more data, there will be more data to build models on. So I think we're boundless when it comes to that. Also, just make your lives easier with mundane tasks that you don't really need to think about, and think about bigger things so we can build better models, I guess.
Yes. helping patients live their best lives, certainly. And Danielle, I'm going to give you the last word on this. Where do you want to see AI go next?
Yeah. And we've all kind of alluded to this, but it's giving clinical AI more autonomy where clinically appropriate and safe. Where can we, automate that orchestration of care to where we can have downstream workflows be more automated, enroll patients in appropriate programs, escalate to care teams, as needed, only when intervention is needed versus having, care managers conduct outreach, assess the patient, then determine it's almost, okay, care manager, this patient's having shortness of breath, we need to call him and bring him in. That's where we're minimizing, redundancy in workflow, but keeping the human involved. I think there's huge implications with workflow optimization, given that staffing shortage is a commonality across most organizations. And then beyond that, I think we'll see, care gap improvements, behavioral health improvements, predictive triage of next best place of care. There's a plethora of use cases, but that's probably the predominant ones as it relates to our conversation today.
It's fun to speculate, and
yes.
And we could have this event again in a year's time, and it would be entirely different. The conversation would be entirely different. But today, this was perfect. I thank you all very much for taking the time out to talk about AI in clinical care today. And that's all the time we have. That's all the time we have for questions. In closing, please note that our Winning Edge program on June 17th, next week, will cover the winning edge for negotiating with vendors. Always a fun topic. A live clickable link for this one will appear at the close of this program, taking you to the registration page for that event. Remember to follow along all week. We're going to have more content out of this. I'm going to be writing a few stories on this. We're going to have the YouTube come out on Friday. So follow Health Leaders all along this week for continued coverage on this event using AI to improve care management. Visit our website, Health Leaders Media. I want to thank our panelists today for once again for this excellent discussion, and our sponsor, Lightbeam Health Solutions, for making today's program possible. Finally, thank you to those in our audience for participating. And when I say we had a good number of people joining us today. We hope you enjoyed today's program, and we look forward to seeing you during our next Winning Edge program and all other Health Leaders events. Thank you very much for joining us today.